It's just loading. It should go there in a second. Okay, it's recording.
Thank you. And good morning. Welcome to the February 22 meeting of Healthwatch Coventry. My name is Stuart Linnell. I'm the chair of Healthwatch Coventry. And if you're viewing on YouTube, you're very welcome to listen in and watch and see our deliberations. If you want to find out more about Healthwatch, you can do that on our website, healthwatchcoventry.co.uk. And our job, our role is to make sure that leaders and decision makers within the NHS hear your voice and use your feedback to make sure that the service is operating as it should be and as you would want it to be. We have a full agenda as always this morning, and our Healthwatch steering group is ready to discuss those items. Just to our steering group members and remind them, if they would please, to make sure that their microphones are on mute unless they want to contribute or are invited to contribute during the course of the meeting. You have a hands up facility to let us know if you want to make your point or say something, make an observation on what's being heard. And we have guests from parts of the health service and the structure within Coventry to join us during the course of today. So you're very welcome. First of all, let me ask if any of our steering group members have any declaration of interests they wish to make known to us. I'll take silence to say that they don't. Also ask you if you've read and received the minutes of the last meeting and whether you're happy that they are an accurate record. And does anyone have any matters arising from the minutes that is not on today's agenda that you want to raise at this point? I'm just checking across my screen to see if anyone wants to join in at this point, but nobody seems to want to, so we're all happy with that. Thank you very much. So we move on to UHCW, their priorities and challenges, it says on my agenda, and certainly both are very much in the minds of a lot of people, I'm sure, at the moment. We welcome Jamie Diaz, who's Director of Strategy from UHCW, Helen Mosley, Strategic Relationships Network Lead from UHCW. Welcome both. Who is going to lead off on this presentation to us this morning?
That's going to be me, Stuart.
Jamie, over to you.
Okay, thank you. Thanks so much for, firstly, thank you very much for inviting myself and Helen to come and have a conversation with the Healthwatch group. It's really appreciated. The purpose of this session is, as Stuart said, it is about our challenges and priorities, and it's actually trying to get. We're having a number of conversations across our system with our workforce and with our partners and with the public in terms of our plans for the future. So we have a strategy in place that actually ran from 2018 to 2021. This is our refreshed version. We're a little bit behind the pace, but obviously, as everybody's aware, there's been quite a lot of pressing issues over the last couple of years that have kind of made it probably not the best time to be thinking about that. But this is now the right time to start thinking about what the future looks like. So hopefully, in the papers, I believe that went out, people saw this document. I think it's a text there. So this is our document, One Hospital. I don't know if it's possible to show any slides while we're doing this presentation.
Yeah, that's fine. I can share them for you now.
Okay. And I'll do a Chris Whitty on you and say next slide if that's okay.
That's fine. Hang on, let me just get
right.
it beginning.
Okay, brilliant. Okay, so as I said, hopefully you've seen the document that we've called More Than a Hospital. And just to be clear, this is really this is our first attempt. This is our draft. Started for 10 to enable us to have some conversations with the people that matter in terms of obviously our patients and the residents of Coventry and Warwickshire, our partners, and obviously our workforce. And so we're doing these sessions over the next couple of months to try and get as much input as possible into this, so it feeds into our final document. And this is a strategy that's going to take us up to 2030. So we're looking in the longer term, which aligns with both other organisations in this great city of ours, in terms of the universities are looking at their strategy up to 2030, and some of the government, the white paper that came out last week about levelling up is up to 2030. So we're looking much more long term now. We're calling this More Than a Hospital because we want to make it really clear. We want to make a really clear signal that we recognise that the good health and well-being of the communities that we serve requires us to look outwards. As a hospital, we've probably been guilty in the past of being a little bit insular and kind of been waiting for people to turn up to on our doorstep, and then we treat them and send them on their way. And this is very much more sending that signal that we really recognise that actually the good health of the communities requires us to look outwards much more and work with the public and work with other providers in preventing ill health and to support the wellbeing of our communities. Obviously, COVID had the single biggest impact on all of us over the past 2 years, and obviously we're working hard, as are all other providers of health and care, to respond to the impact that's had. So people will be very much aware of backlogs to elective services and operations and consultations, which is obviously very challenging, as is the demand on our front door services, and also in terms of trying to get people home when they're ready, when they're fit for discharge. There are significant issues across the whole of the system in terms of managing that, and that creates its own issues within our hospital, but also across the broader piece. I guess one of the things that we can take from COVID, it did act as a springboard for transformation. So the collective response to that was across the piece was incredible. We all did things very quickly that we've been probably talking years about doing. So, for example, we're having a meeting now on Zoom. This would have been very difficult 2 years ago. We wouldn't have thought about this. We'd have found lots of ways to find out why it wasn't suitable, but we did it. And in terms of my experience within the hospital, we've worked very closely with our communities, with businesses, with individuals, being very agile with those big changes, focusing on building community resilience, and being much more mindful of the prevention and proactive care agenda, moving away from what I describe as a care and repair model. The other big changes that are on the way, things that are coming into play now, which have been discussed over the last few years, is the way healthcare is actually organised at local levels. When the Health and Care Act is going through Parliament at the moment, expected to be passed into law by July this year, and that's going to effectively transfer a lot of the commissioning decisions to local partnerships. So this is going to mean it's going to have a massive impact on the way that decisions are made, and the way that population-based budgets are spent will become the responsibility of what will become known as care collaboratives across footprints. Coventry having its own, Warwickshire having its own one, too, and then relating that into integrated care boards and systems. Obviously, UHCW will play a key role in that as one of the big players in Coventry and Warwickshire, and therefore our strategy needs to reflect on that. So if you go to the next slide, please. So at UHCW, we kind of describe our strategy using what we call a strategic triangle, and our existing triangle doesn't look that much different to this, other than there's far more on it. But this is our proposed way forward. So as always, we want to make sure that the patient is our prime concern, which is why the patient is always at the top of our triangle. And we've had a vision since 2014, which is about to be a national and international leader in healthcare. And you'll see there's a subtle change to this vision now, which we've added a comma, and we've got rooted in our communities. This is primarily this is our key change. So this more than a hospital strategy that we've got recognises that actually the good health of our population is not just about being a hospital. It's about people having access to good housing, employment, education, the environment being decent. And so to this end, we're working very closely with some of the other anchor organisations in Coventry, Warwickshire, so the universities, the local authorities, some of the other health providers, to maximise our collective resources. So recognising as big organisations, we have a big impact to play, and some of those wider determinants of health, such as employment, training, education, making sure we spend the Coventry and Warwickshire pound in Coventry and Warwickshire where we can, and also being really focused on reducing our carbon footprint. We are big contributors to that carbon footprint across Coventry and Warwickshire, so being really mindful of our responsibilities in those areas. And just to put it in context, UHCW, we employ about 10,000 people across Coventry and Warwickshire, and about 90% of those people actually live in Coventry and Warwickshire with their families. So actually, as a organisation, we're very, very much rooted in our community. And our friends, our staff and their families are also users of our services. So it's within our interest to be very much focused around our local footprint. So it still means being exceptional in everything we do, but it's about being much more proactive, providing joined up support for our local people, but also developing our specialised services. I'll talk a little bit more about in a moment. And above all, we realise that this change in health and care landscape, we still aim to be an outstanding partner, but in local care. And our regional work is an enabler to improve care and quality outcomes for everybody. So it means that where we talk about excellence, national and international, that's national and international excellence for the population of Coventry and Warwickshire. We've got there 3 purposes, which I'll talk about in a bit more detail in the next couple of minutes. Underpinning all of this, our values are there for you to see, and they're very important to us, and that's we aim to be a value-based organisation. And then the underpinning part of this is we've had a relationship with Virginia Mason Institute from the United States, one of only 5 hospitals in England and Wales that were chosen to be partnered with Virginia Mason. And this is all about our improvement methodology. So this is running our improvement methodology through everything we do. And you'll hear, if you come to UXCW, hopefully you'll hear people talking about this notion of better never stop. So how do we make tomorrow better than today? Is that notion of how we want to work and how we build upon our future model. So if you go to the next slide, please. So very briefly, we're looking at having 3 purposes. So these are our 3 key purposes. So number 1, and the primary one, is local integrated care. So that really means, as it says there, collaborating with partners to integrate services, improve population health, and tackle health inequalities. And so some of the things that we're doing in this area, just to give you an idea of the practical things we're doing, we're looking at where we can establish a community diagnostic centre in Coventry City Centre, which effectively will bring rapid access to a much broader range of our population in a much more convenient position. So off the hospital site and in a city centre, making it more accessible for people to get those diagnostic tests that they require. So their CT scans, their MRI, ultrasound scans. So really trying to address much earlier how people access a diagnosis for things such as cancer, but on a much broader range of other things like respiratory and cardiac diagnostics. We've also just completed with our other health and care partners a diagnostic of the pathway of care for our older population, so people over age 65. So looking how we can improve outcomes and experiences for those people by reducing the number of attendances at our front door, reducing the number of people that get admitted that turn up at our front door into the hospital, reducing how long they stay in a hospital and they're fit to go home, and also improving those step down and rehabilitation services. So this is much broader than the services that UHCW offers. This is our primary care offer, our community care offer, and our social care and voluntary care offer. And so what we want to do with that is, as we move forward, is look at how we can improve all of those things to actually improve the flow for patients, but much more important than that is improve the outcomes and the experience they get of using the services, and much better health outcomes. We're also in the process of expanding our emergency department. If you've been to the UHCW site recently, you'll see some work going on at the front, while we're developing our minor injuries unit, which is part of a £15 million investment, which will also include expanding our main footprint in the emergency department to make those facilities much more attractive and comfortable for the people that need to use them. And in the city centre, we're also going to be taking control of the urgent treatment centre, which comes under our, so we will start managing and delivering that as from April 1st this year. So that will be in the City of Coventry Health Centre. We've also been working for a while now with our primary care and community providers to join up pathways for the long-term conditions. Some long-term conditions that are major contributors to people's ill health in Coventry and Warwickshire, so diabetes, heart failure, COPD, etc. We want to reduce the reliance on acute care services and support people in their own homes or in the community, and actually to prevent people from ill health. And doing that in partnership with primary care and community care and voluntary sector again. We've recently put in a new model of care for people with musculoskeletal issues. That's already significantly reduced referrals into acute care, where people in the past may have been referred to an acute provider, where actually what they really required was access to something right at the front door of primary care. So working with the primary care networks, we've put in place first contact practitioners that are having a massive impact already on the numbers of people that are getting the right care at the right time in the right place. Some of the bigger things that we're doing in the future, we'll be looking at how we use population health information to inform what services are required both now and in the future, and help us to collectively plan more effectively. And from a UHDW perspective, we've also developed a tool which has been rolled out across the country, actually, which looks at how we can do a health inequality impact assessment on our waiting list for elective care to make sure that we're not increasing health inequalities by missing those people that need to access the services in the most prompt way. We were expecting an announcement on Monday from the government about the plan for reducing the elective backlog, which you're probably all aware of, has been delayed for whatever reason. One of the things that has been trailed from that is a computer app that people can basically get access to called try to think what that's called.
Might be called the plan.
That's it. My plan carrot, yes. Yes, that's a working title. So that effectively means that people will be able to look online for their own, if they've got an elective operation, and find somewhere where they can get it done more quickly. I haven't seen it yet, and I don't know what the rest of the plan is, but rest assured, as soon as it comes out, we will let you know. So in terms of the second bit then, so being a regional centre of excellence, so this basically means that it's developing our strongest specialties. So UHCW is a teaching hospital. We do provide obviously a range of the full range of services for our local population. We are the provider of a number of specialist services, and this is about developing those to meet the needs of a broader population, but really focusing on Coventry and Warwickshire. And we're doing some things to help us do that. We're looking at how we use our Rugby St Cross site in a more effective way to increase the amount of elective operations that we can do on that site, which then releases capacity on our Coventry site, that therefore enables us to manage our major trauma and our more specialist procedures without impacting on elective operations. The last thing we want to see is where somebody's booked in for an operation and it gets cancelled or delayed because an emergency has come in and taken the theatre space. So we're looking at how we can use that site much more effectively to do that. And that then will enable us to expand our specialist services as well on a wider geographical footprint. We've already opened 2 new theatres in Rugby in the last 6 months, and we're planning to open more over the next 12 to 18 months, as well as increasing some of the diagnostic capacity on that site as well. And then finally, last but not least on our key purposes is this research, innovation and training bit. So we recognise that if we want to be a national international leader in healthcare reach in our communities, we need to expand our research and innovation portfolio so we can recruit and retain the best staff. I guess people are aware that we were the first site in the world to deliver a COVID vaccine. We're very proud of that. It wasn't through chance that happened. It was because of the reputation and the work that we've done in the past, which enabled us to do that. And we also run several other national and international clinical trials, lots of them around COVID. Some of those we were also some of the first areas in the world to run those in terms of treatment, and also trailblazing some of the treatments in long COVID. And we've got a plethora of other research areas in other areas. And in terms of things like innovation, we're developing close ties with organisations like the Local Enterprise Partnership, and working with individuals and companies developing new ideas to improve healthcare, and also ideas that help us reduce our carbon footprint, which I talked about before, which is a kind of a big issue for us, and how we utilise technology and new processes to make things better. So that kind of innovation territory is really important. We also recognise that actually without the right workforce in place, that none of this makes any difference. So we can build all the theatres that we want and all the diagnostic class we want. We haven't got the staff to work in them, then we can't deliver them. So we're really keen to work, and we are working very closely with our local universities and further education providers, and moving into school territory as well, to start looking at encouraging young people to come and work in the National Health Service, and also to train and develop both our future and current workforce. And all this is underpinned with our broader plans for our workforce, continuous improvement, investing in digital technology you'd expect, in data insights, and ensuring that we are a sustainable organisation. So if you just want to go to the last slide. So this is our what's next slide. So we've developed some printed and online material, including the brochure that was sent through to you. We've also got a really good short video called More Than a Hospital, which is a great, it's 3-4 minutes, and it kind of gives you a really good idea of all of the services that we do and all the people that we're involved with, and how we are much more than a hospital. I would encourage you to watch that. And we've also got an online survey, which you can see there's a QR code on the screen there, which if you just put your smartphone in front of it on the camera, it'll take you through to a survey, which effectively is our public survey. And we've got one survey that we've got for our staff. These have been analysed independently by another company, which will basically help us to understand all of the feedback that's coming back through around our strategy, and it will inform the final strategy. So right at the beginning, this is not the final document. There's also an email address there if people would rather kind of comment in that way. So I guess what my ask from yourselves would be is, in terms of your broader networks, it'd be really helpful if you could encourage people to have a look at what we're planning, those thoughts, and really if they could do the online survey, that really helps in terms of shaping what the final version of this looks like. I've got no more to say on that. Thank you very much for your time, and obviously I'm open for any questions on anything you've heard. Thank you.
Thank you, Jamie. If anybody wants to ask a question, by all means raise your hand and we'll come to you. Could I just ask a question of Helen, who's been sitting there making sure that you didn't forget anything? Helen, when we talk about strategic relationships, which is in your title, explain what you mean by that specifically, because of course during COVID we've learned a lot more about working together and how important those relationships are right across the board, haven't we?
Very much so, yes. So thank you. Hi everyone. So it's a fairly that's like one of my interview questions, Stuart. It's a fairly new role that I'm occupying. It's a fairly new role for the organisation, but I think it is, as you said, recognition of how important partnerships are and relationships will be going forward. We, as Jamie said, I think could have been accused of being a bit insular in the past. We're really keen now that we have much more kind of outreach into the community, much more outreach with our partners. I think the strategy itself, when we talk about some of the priorities and challenges that we have, I think it says we can't do this alone. And you know, the integrated care agenda, and we apologise for the buzzwords that we probably used, that is all about delivering care and services in partnership. So it is about building those relationships to help us deliver some of those things. Stuart, if you want, I mean, I'm happy to come back at a future meeting and talk about some of the practical things we're going to be doing, but I'm just kind of getting my teeth into some of the role at the moment.
Indeed. Thank you very much. We've got one or two people wanting to ask questions and make contributions. So Apollo, let's come to you first of all, please.
Thank you very much indeed, Chair. Yes, there's a question really about the digital side. There's a couple of statements in the document that talks about optimising the digital health literacy of the population and patients to take control of their own healthcare with access to digital records. I wonder how you see that working, Jamie.
Yeah, so I think the apologies for the kind of use of language in there, because it all sounds very kind of, what does that mean, doesn't it? I guess what we mean is the way that, in terms of digital literacy, it works both ways in terms of digital literacy within our own organisation. So the way that we use data and information to make decisions and to communicate, it's improving upon that. And part of our big investment in that is we are rolling out a major electronic patient record system it's actually starting now, actually, which will be a way of joining up health and care records, not just across our organisation, because we're aware of the silos that exist within the hospital, but then there's also the fact that a lot of this stuff doesn't necessarily join up with those systems that go across our system. So there's a real push, both from a UHCW perspective, but also across systems to join those up, and using that information in a much more effective way. So things like population health management information to enable us to be much more effective in making those future decisions. And from a public and a patient perspective, it's enabling people to be able to make their own decisions about how they access our services and information related to the services, and also how they provide the data that can sometimes be delivered through digital means at home, if you like, which means they don't have to come into hospital all the time. So preventing people coming onto our site all the time when they don't necessarily need to do that. Also recognising that actually there are some people where that is not going to be practicable, and also where in some instances it's not the most favourable way of doing it. So that's what that means in very sort of highfalutin language.
Thank you. Is that okay, Apollo?
Yeah, there's just
Yes,
the issue of accessing records, the patient accessing their own records. Do you actually see that as a likelihood where you can tap in, go online, and you can look at your records, as some GP practices allow, some don't, mind you, but some do. Do you see that that the way forward?
Yes, yeah, that's in our digital strategy in terms of patients having access to their own records through a portal.
Okay.
It's in one of the first phases, yeah.
Thank you. Okay. Look forward.
Thank you, Apollo. Ed, please.
Sorry, I was just in a meeting. Thank you for that presentation, and I enjoyed reading your document. I think the themes of community and place are really important, and learning from COVID. So just some feedback on the strategy. I really like the case study you have in there of the guy who goes to his GP and how that links up with the work of your hospital, etc. I think for me, the real lesson of COVID was this miscommunication between care homes and hospitals. And we really need to learn something from that. So if I was doing this document and talking about all the future plans that you mentioned and how you're going to work with social care, you could include a case study actually of that. This is something new we're doing. Working with GPs, I don't see that as that new. And if there was a case study on these plans of how you're going to work with the council or care home providers, that would be something really welcome to me. Thank you.
Thanks. That's really good feedback. We'll definitely take that on board. Yeah, you're absolutely right.
Thank you. Apollo, if you could take your hand down, that would be helpful. I think you may have done already. David.
Thank you, Chair, and thank you for the presentation. It's written in plain English, which I much appreciate. Now, Jamie, you might think this is nitpicking and you're looking at the big strategy picture, but I think for the community, transport is an important issue. And the latest statistics were that less than 25% of people in Coventry don't have a car. We're looking at dermatology proposals later on, where it seems to me that the outpatients will either go to George Eliot or St. Cross. Now, I've got a personal interest in this. I've driven for 50 years, but 6 months ago I had to stop because of poor eyesight. I know that getting to St. Cross and George Eliot by public transport, even if you live in those towns, is not easy. But if you've got to come from Coventry, I had to go to orthopedics at Rugby by public transport, and it took me 2.5 hours from Coventry. Even in Coventry, I live in Tile Hill, I have to get 2 buses, it's an hour's journey. But your hospital has got an excellent bus hub, and therefore people in Rugby and Nuneaton might say, and South Warwickshire might say, dermatology all in Coventry is not good, but they can get to UHCW by public transport. I've got to get to UHCW on Wednesday for an appointment, and I will leave an hour and a half before to get there on buses. I do think when you're drawing up these bold strategy plans, and I fully understand the need to use the satellite hospitals, you ought to bear in mind the lack of public transport. Thank you.
Yeah, okay, thanks for that, David. There's a couple of things there. One is, and I'll take them in turn. So in terms of dermatology, we wouldn't expect anybody, we wouldn't be expecting anybody from Coventry to travel to Nuneaton or Rugby for an outpatient appointment for dermatology. So that wouldn't be in our plans. We're looking at options for dermatologists, which, as you're probably aware, but it would be what we effectively want to do. We want to ensure that care is as close to people's homes as it possibly can be. So, so just to reassure you, we wouldn't be looking at outpatient appointments for Coventry residents within either Rugby or Nuneaton. It would be in Coventry. Hopefully that.
Can I just
answer the question?
Can I just come back on that? I must have misread the letter. We've got 2 letters from Andy Hardy about this, and I'm sure that in the second letter that went to Stuart, it said that the proposal is that outpatients would be not at UHCW but at St Cross and George Eliot. But maybe I've not read it correctly.
There were some temporary arrangements made as part of the response, but it isn't our future plan. But if that puts it that way.
All right, I accept that. Do you also accept, though, that when you consider the movement of people, whether it's from Coventry to North Warwickshire hospitals and Rugby, or whether it's people from Rugby and Coventry coming in, that how they're going to get there is something you have to consider. For example, people should not be given a 9 a.m. appointment at St Cross for orthopedics because you can't get there by bus by 9 o'clock, and it would cost £50 by taxi.
Yeah, absolutely, and that is something that we will take on board. If that's happening, that's obviously not that's not a good experience or an outcome for any patients. What we want to do, just to kind of round off, what we actually want to do is look at how do we provide our services that are much more accessible, either by location. So how do we get those? How are we more rooted in the community element of the geography that we operate in? How can we, where possible, where practical, can we reduce the number of outpatient appointments we need to give out, and if possible, how can we make those more accessible through other forms, which don't necessarily mean coming onto a hospital site? That's kind of what we're looking at, taking into account that some people may find that very difficult. Absolutely, but I will take your comments on board.
Just to add to that, Jamie, from a Healthwatch Coventry point of view, I mean, this has been an issue for people who live in Coventry for quite a long time, really, in terms of where services get located. So therefore, it is something that we're kind of happy to talk with UHCW about and work with UHCW around in terms of where there are service changes and service plans being put in place. So we have produced reports on this in the past, for example, asking people around their issues and their challenges around getting to different locations. And some of the findings from that are a little surprising in a way, in that even people who do have access to a car, so some of the population groups who might use services more, for example, might still find it quite challenging to make those journeys. So I think there's quite a lot to be understood and considered, really. But obviously we do understand the sort of direction of travel in terms of, I guess, from a service point of view, what you would like to have in place.
Okay, thank you for that, and thank you for raising that, David. I'm sure Jamie's taken that away. Pamela, you have your hand up. You're muted at the moment. That's it.
Okay. Okay. Thank you, Chairman. The proposal is quite commendable. Actually, it's more about a comment. I also understand that this strategic planning is as part of the test of time, like using the right approach, like the co-production approach, whereby we'll be getting the community, the individuals involved to ensure sustainability and cost effectiveness through the survey and others. So I just want to understand that if the survey and the getting to hear feedback from the community should really be encouraged, because whatever strategy we're trying to work out is actually for the people, and to ensure that yes, it's feasible and it's sustainable. Thank you.
Yeah, And absolutely, we recognise that that our aspiration is to co-produce our redesigns as we move forward with that. And we're really eager to learn from community groups and individuals and people in the community in terms of how we do that better, because we recognise we haven't been that good in the past with that. And it might be something that Helen could come in on in terms of her role as strategic relationship network lead. It's the sort of area she would be focusing on in terms of how do we do that better, how do we use the feedback in a much more effective way than perhaps we have in the past.
I mean, just to add to that, I think, you know, in the kind of time I've been kind of working at the hospital, we're looking at kind of all the insight that we sit on as a hospital actually, and how do we triangulate all that actually? How do we make it meaningful to all of us rather than it sit in pockets, and then think about what coordinated action we need to do? Equally, all the insight community groups have. So we need to get better about joining up on that, I think.
Thank you. Can I just add one question from on my behalf as well? Under your heading local integrated care, I notice you make understandably great play of your work regarding health inequalities. My good friend Jagtar Singh, who you'll know is the chair of CWPT, uses the phrase that that health inequalities, he regards them as avoidable and preventable. And I think that's a phrase that stuck with me, and I think he's absolutely right. The work UHCW is doing in that respect, to me, it seems, should be leading the way in the city. Is that how you see it?
Yes, and as I said, within internally, we've to bolster that commitment. We've jointly employed with the City Council a lead in public health, who is actually working. Her remit is working specifically on health inequalities, and has helped do this piece of work in terms of how we ensure that when we're looking at our elected list as a starting point, really, so this is a trailblazer on that, how do we make sure that we're not creating more inequalities? What tends to happen is those people who come from who are less impacted by health inequalities are normally the first on the list. And so this tool actually helps us to identify where we're possibly missing people and opportunities, but because they have a lesser opportunity. So that's an area that we really want to focus on in terms of as we move forward, as kind of the biggest, as one of the anchor points of the conference. It's something we really want to focus on, because actually those people then end up having worse outcomes and actually need to use hospital services far more often as they get older. So it's kind of, it's a win-win. And so we would see that as a real kind of area we want to focus on. Yes, and I agree with Jag Tara on that one. As I agree with him on everything. So.
Very, very sensible. Just one final question from me. You used the term universities plural. Could you just outline the different ways in which you engage with the two institutions?
Yes. So with Warwick University, they're our partner with the medical school. So the Warwick Medical School is our kind of partner in terms of so that's around our medical workforce, doctors, consultants, etc. Coventry University is primarily around our nursing and allied health professional grouping. So from a workforce perspective, that's how that sits. But we work with them both equally in terms of research and development. And we have kind of representation on our board from both those organisations.
Good to know. Thank you. Anyone else?
Yeah.
Sorry, go on.
I was just going to say one of the things that we really want to focus on in terms of developing our diagnostics centre I mentioned earlier on is working with Coventry University in terms of working in collaboration so we can train the workforce for the future, because that's where there's a significant deficit of staff. And so by training them and trying to keep them in Coventry, they then become our future workforce, and that's a really good key strategic relationship.
And that's probably the biggest challenge, that last bit, retaining them in this area, isn't it?
Yes, yeah, they tend to, historically, people will train in one area, then go somewhere else, which is very difficult. But yeah, so we're trying to change that kind of, so that they stay here. Or they're from here in the first place, maybe, I don't know.
Thank you. Anyone else want to contribute? Last minute or so. Are we all done? I think we are. Well, look, thank you both very much indeed for your time, and thank you for joining us. I hope it's been useful to you to talk to us, and I'm sure our members will have learnt a lot from both the paper you circulated and from your presentation this morning. So thank you very much indeed, both of you.
Stuart, just to say, please,
Thank
if
you very
there's
much.
any further
Thanks for inviting
comments,
us.
please let us have them. And we see it as an ongoing conversation with you. So we will come back to you in the future. Thanks for your time.
Look forward to it. Thank you both very much. Thank you.
Thank you.
Thank you, Jamie. Thank you, Helen. And as you heard from Helen, they're welcoming any further comments. If anyone wants to pass them on through our office, we can certainly do that with great pleasure. So, Healthwatch activity then, Ruth, and dermatology was mentioned quite a bit there. That's where we start, isn't it?
Yes, so we've spoken about dermatology at our steering group meetings in the past. So some of you will have taken part in those discussions, not the new members. So we did have an action from our last steering group to send information requests to UHCW. But the chain of events was that we got a letter from UHCW almost straight away, providing some information, which is the first letter that you've got, paper 2. And then I worked with Stuart to send in another letter asking for some more detailed information. So paper 3 is the answer to that. So the question for you as a group is, have you got enough information, or have you got further questions? And are there any actions that you want Healthwatch to take to understand the position further?
All silent. David, you got a hand up.
Yes, I have. Look, I just want to follow up what I was saying before. I hate to go on about it, but this is what it says in the letter. New service proposals, our service vision, dermatology. Our preference is to provide a hub and spoke model with a community-based hub for the majority of services and a smaller UHCW footprint reserved for acute site activity only, and the continuation of outpatient provision at the Hospital of St. Cross and George Eliot Hospital. So according to that, Jamie was quite wrong when he said we will continue to provide provision for minor situations at UHCW. And this is, I'm afraid, what people, as Ruth has said, we've been banging on about transport for most of our last 10 years. And they really don't take it seriously. People who are, I can speak on the 2 sides now. I automatically had my car parked outside. I walked out, I got in it, I could drive to anywhere I wanted to. If you haven't got a car, it ain't easy. And he does not read his own stuff there, because it does say definitely that acute site activity only at UHCW. So therefore, if you've got a dermatology problem, you'll have to go to St. Cross or George Eliot. Sorry to bring it up again, but I think it's
all, David. Absolutely right to do so. We're meeting, by the way, with Andy Hardy at the end of this month. We have a meeting scheduled on the 25th of this month, so we can certainly make sure that's raised.
Well, we could ask for, because they've named a particular individual, haven't they, in the letter, as somebody to have further conversations with. So we could potentially ask for them to join us at that meeting to seek further clarification. So I think it's a complicated picture what's happening with dermatology, and I'm not sure we have all the information at the moment. So that there's
real frustration. The real frustration here as well, David, is that when we last had a Healthwatch conference face to face, which obviously must have been 2 years ago now, because of COVID, the then chief executive of the health service, NHS, Sir David Stevens, said, he stood up there and said, I understand this issue with transport fully. And he addressed in his speech to the conference quite a section of it about transport to and from services, whether they be at hospitals, doctor surgeries, or wherever. And he comes from Birmingham, actually. He cited the example of his own mother having to go very much on the sort of situation you've been in, going to and from hospital services and clinics in Birmingham. So it's been understood at the highest level. So it's extremely frustrating to find the situation you're describing happening on the ground in front of us right now.
Yes, thank you, Stuart. You're quite right.
Yeah. So in terms of dermatology services specifically, so there's been a moving around of where things are delivered, which we've been trying to understand. So what's actually happening now? And then what we've also been advised of from a Healthwatch point of view is that there's going to be a longer term plan in terms of where services are located. So I don't think we've had any information about that longer term plan as yet. Maybe it as yet doesn't kind of exist really. So Stuart and I have also had some conversations with people from the CCG, because there's a kind of threshold in terms of when is what's a service change and when does it kind of meet the threshold for the kind of consultation and involvement around the service change. I mean, you would hope on the basis as well of what we've just heard today from UHCW's presentation that actually the way forward and the direction of travel is actually to involve people really quite early on. So I think they've indicated some small mechanisms that are being put in place to speak to dermatology patients at the moment. So it might be interesting to see how that could be built on perhaps as well. So
Apollo, did you have your hand up, by the way? You're muted, Apollo. You're muted. Apollo, you're muted. You're muted, Apollo.
Sorry, Stuart. Yes, it's a nitpicker. The first letter, inconsistency in the development of specialist nurse workforce, presumably means they can't get enough of them. Sorry, that's a nitpicker, and I apologise for that. That's why I put my hand up. But I'm assuming that's what it means.
Yeah, dermatology is one of the specialties where there are some of the biggest workforce pressures. Okay. Not enough staff, around the country.
No, thanks.
Anything further on that, Ruth?
Okay, so in terms of actions then, what I'm kind of understanding is that people aren't quite clear, are they, in terms of what the plans are and where services are being delivered and are going to be delivered from. So I think if it's okay with everybody, we'll try to follow it up through that meeting with Andy Hardy as a kind of touch-in point. I suppose just an observation, I guess, as well off the back of the presentation that we just had from UHW, which was really useful, wasn't it, to hear about some of the areas of work. It does sometimes feel like we're not kind of connected in enough, I think, with some of this developing work. So there was mention around the diagnostic hubs stuff. So I have been sitting on a group which relates to diagnostic hubs. But again, I'm not sure that kind of takes you inside it, if you see what I mean. So that's something as well that we probably need to explore with UHW, isn't it? And I think their new strategic priorities are a good driver for trying to put something in place.
Good, thank you. I noticed your comment, Ed. I do apologise for not bringing that up while they were with us, about Stony Stanton Road and so on. I think it's slightly different to how it used to be from what they were saying. I think it's more of a clinic within rather than the actual facility itself, but it's one for us to keep an eye on. Thank you for that. Sorry, Ruth, anything more on Healthwatch activity from you now?
Okay, so just in terms of the urgent treatment centre, so that's interesting to say that they said they were going to take over the running of that for the 1st of April, because I thought they would have run it. So that's the new name for what's called the walk-in centre. So the place where you can kind of turn up. So it was a few years ago, but there was a kind of model for that kind of front-facing centre that was developed nationally by NHS England to say that there needed to be urgent treatment centres that were kind of run in the same way across different areas of the country. So I think perhaps one of the things that might not be being considered at the moment is that some of the professionals are calling it the urgent treatment centre, but everybody still knows it as the walk-in centre. It's like, is it different or is it the same? And how do you actually ensure that people understand that it's not another thing that's going into the City of Coventry Health Centre? It is the sort of ongoing service that's already there, and that building holds a number of different services. So people tend to refer to the whole building as the walk-in centre as well, when actually it's a multi-use building with lots of different NHS services within it.
Just a quick comment. The RICO is still the RICO, isn't it, Stuart? And people will call it the walk-in centre for years and years and years.
The RICO's the RICO until we want to call it something else, David, basically. Absolutely. CBS makes it sound like it's an American movie set, but anyway, we'll see. Rose, you have your hand up. You're muted, Rose.
Thank you.
Oh, sorry.
Can you hear me now?
Yes, we can.
Thank you. Well, just to let you know, the group, I had two very good experiences at the walk-in centre, or the other name for the service. I actually got to see a GP. I hadn't been able to get in to see my GP for about 6 months, actually. So I walked up there about 8 o'clock in the morning and seen a doctor straight away. And it was a junior doctor that told me the change in name. So because of that experience, I told another friend about, if you wanted to see a doctor, go to the walk-in centre. They've changed their kind of priority. So I think you are right in saying that people need to know the changes, if that makes sense, because I was pleasantly surprised. Is that okay?
Very much okay. Yes, you're quite right. I mean, people do need to know. Communication is something else that we continually refer back to in so many different ways. At the same time, you know, in fairness to some degree, I hate being fair to them sometimes, but in fairness to some degree, when you talk about communication, there are so many different ways that messages are passed on. But, you know, once upon a time in this city, it was more than sufficient to buy the Coventry Evening Telegraph. Well, few people buy the Coventry Telegraph now, or let alone read it online. There's a local radio station. Not everybody listens to it. A lot of people do. Not everybody does.
Yeah.
And we've seen in the past few weeks, Coventry City Council sending letters through our door telling us when the bins are going to be collected, letters which has information which is out of date before they even put it in your letterbox.
Right.
And now they're, you know, people in my street I know today were surprised to see bins being emptied and they hadn't put theirs out because they've got this private company doing it. So getting back to the health service, I'm sure similar things can occur, that they could pass the information on, but not that everybody sees it anyway. But it's a very good point. Communication is critical, Ruth, isn't it, to so much that goes on?
Yeah. Absolutely, yeah. But sometimes it gets forgotten as well. It's just like everybody in the system bit knows what's going on. So it's like actually explaining that in a way that people can understand is really important, isn't it?
Having said what I just did, my wife is just about to go out with her mother. Just pass me a note to say the bin men haven't been yet. This is the day they're supposed to come. Providing they do, please put the bin in the front garden so no one else uses it. So that's my job this afternoon.
Shall I go on with the
hopefully
other papers, the activity report and the emergency issues report? So
yes,
we always
please.
have an activity report on the agenda. So this is where we report against the work priorities which the steering group has set. So I've done a bit of restructuring to the paper this time because we've refreshed the work priorities. And then you've also got paper 5 and paper 6. So paper 5 is our emerging issues sort of logging paper. And paper 6 is what Healthwatch England produce every month or so. And we're trying to sort of adopt some of the method that Healthwatch England are using in terms of sort of identifying some of the things that are coming up the track, as well as the things that we're working on. So for paper 5, the emerging issues, things might go on there and then they might come off again, or they might then go for further consideration for whether we need to do work related to the points. So this is the emerging issues log as is at the moment. So as we've got sort of channels of communication coming into us as a Healthwatch, where we're hearing from local people about their experiences, this could be quite fluid essentially. So I was just sort of reflecting in preparation for this meeting that in terms of some of the calls and things that we've been getting to our information helpline over recent weeks, they might be starting to identify some new areas potentially. So that's what we're trying to capture on this. So in terms of the papers, we're just trying to give you some information in terms of activity that's been done and the things that we're focusing on. I suppose that the big take home from this paper in terms of where a lot of the effort has been going over the last couple of months in terms of the work priorities has been about number 3, which is the relationship and influence of Healthwatch in the new NHS structures, the Healthwatch role, and then of course the voices of patients and the public. So that's understandable given all the change that's going on and the necessity of thinking that through. We've also done some follow-up actions around our reports and recommendations around GP phone systems as well under 1. We've been establishing our clear information volunteer group. I'm pleased now that we have a DT with us as our volunteering coordinator so that we can take forward more in relation to our different volunteering roles and develop and enhance that. So that is around information and how you inform people about stuff. So it's at the very practical end in terms of when something's drafted, is it going to make sense to people? So as identified though in this meeting, there are other areas around communication and getting messages to people which are also important. So has anybody got any questions around any of that information? So in terms of the staff team, so our engagement and outreach coordinator will be joining us as a new person into the team from the 1st of March, although we have now lost our information signposting officer who was Phil, who's left the team. So that post is now out for advertisement. So we still don't have all the posts filled in the team, unfortunately. So that is an ongoing challenge, really, and the kind of job market as it is at the moment, and what that means for recruitment.
Okay, thank you. Any comments, any observations anyway? Okay, and you've got the Healthwatch England paper for information to, if you haven't already had the chance to look at it. So we move, I think, don't we, Ruth, to Healthwatch representatives reports. Anybody extended a meeting or group externally that we've not had sight of or wants to contribute to us now?
Yeah, so you've got some quite detailed reports from representatives who've been to different things. Just to also say that David has been our representative on Scrutiny Board 5 Health and Social Care Scrutiny at the Council for a long time. And I know that David would like to pass that role on to somebody else within the steering group, so that there's one meeting scheduled now in what they call the municipal year for the council, because it kind of runs election to election. I won't put people on the spot, but if anybody would like to understand more about scrutiny and might be interested to take on that role, and to understand what it entails, if you can kind of get in touch with me. It has usually been the kind of individual members of the steering group who've done that. That's to say that it couldn't be a Vonchsepta member, but it's about hats, isn't it? And about which hats people are wearing at things and making that clear. So if you could have a think about that and get in touch with us. So scrutiny, as it says, its role is to scrutinise how health and social care is delivered in Coventry. So there is quite a synergy with our function as a Healthwatch. It also enables us to work with local councillors, which is really beneficial for us as a Healthwatch, and for them to kind of maintain their understanding of us and the work that we're doing. David.
Yes, thank you, Ruth. I have been doing it for the 10 years, I think. So it is an important role. I think Stuart, who attended a couple of meetings when I was not available, and I are of the same opinion that it hasn't really been working very well for the last year or so. I've also conveyed that to Vicky Castri, who's the person who works in the advisory capacity to scrutiny, but it's got a lot of power. For example, senior health and social care people can be called to scrutiny. Andy Hardy a couple of times has been called when scrutiny has felt that something has been going badly wrong, and they have to be held to account. And we always felt, Ruth and I, that there was a good combination, and we've worked with different chairs of scrutiny, and they've always said what Healthwatch can do, and hopefully we'll be able to do a lot more again in the future, is to do the visits, the enter and view and the finding out stuff, and putting together it all in reports and so on, which scrutiny can't do. But then they've got the power, if they so are mindful, to, if there's particularly something going wrong, but maybe even if there's something going brilliantly well, to actually bring it up, So again, I think what you'd agree, Ruth, in an ideal world, it would work well for Healthwatch and scrutiny.
Yes,
and scrutiny
right.
carries on in the new health and social care system as well, and that kind of sort of holding things to account function is going to be important as well. So.
Yes, you're quite right, David. And I think we've said before that these committees very often are as effective as they take their lead in effectiveness from their chair. And I think that's not casting any aspersions against Councillor Clifford, who is the current chair, that maybe a fresh look at how it runs would not be a bad idea. Let's put it like that. But thank you, David, very much. And thank you for your time on that. And if anyone would like to step forward now, we've made a lot of play of David's longevity and old age in this meeting today, with great affection, I have to say. But if anybody would like to step forward and take up the mantle that he can now hand on with great experience, then please do let us know, and we'll be happy to take that on board. And thank you, David, for all you've done there.
Can I say, I had no hair when I started on Healthwatch, so it's not all the worry that it's caused. Thanks, Stuart.
So in terms of the other reps reports that you've got there, so we've got people going to various things on behalf of Healthwatch. This is what it's all about, essentially. So people go with the hat of Healthwatch. So it's about going and kind of representing your own experiences or that sort of thing. So this is a kind of model to be thought about in terms of the new health and care structures. So has anybody got anything that they wanted to ask any of the people that had been to any of these meetings, or anybody who's been to anything want to highlight anything that they think is the most important thing?
May I raise a point, please? Apollo?
Please do, Apollo, yeah.
Thank you very much indeed. I'm looking at the primary care quality report, and there's once again, I mean, we know CQC have paused everything, but they've left the implying all practices are okay, and a later part of that discussion was the general picture was good. Well, it isn't. I mean, talking to a lot of people about this, there is still a lot of issues, and Healthwatch knows this very well about access to appointments, etc. Now, I took it upon myself to look at a couple of health centres around the country, and I picked one in particular from Cheshire, from Wilmslow, and where you have an online system where if you have a request to see somebody in the practice, you put a request in about what the condition is, who the patient is, it's validated by a code sent to you, and then it's evaluated and it's triaged, and they guarantee within 1 day. And the person I spoke to, who happened to be my daughter actually, she has, for both for her and her son, within an hour, who they're saying a appropriate person, etc., etc. Now, that is what I would call a sensible use, where possible, of digital technology. The people I've spoken to from a number of practices, including my own, who do not use it, and we have the lottery of the 8 o'clock phone call. Now, I've brought this up a number of times, and I know Healthwatch has brought this up a number of times. Now, I don't know what we can do, Chair. I mean, there are better ways of doing this. The software used by this particular outfit are it's something called Flory, and it's a company that produces software for the NHS. Now, I shall be bringing up our patient reference group tomorrow, which I hope will start. But we're getting nowhere. We're going round and round in circles with some practices, especially like my own. And I think there must be some way of that. And I believe you can access money. Practices can access money for this. So I'm not quite sure what the issue is yet. I don't know what Healthwatch can do, but it keeps coming up time and time and time again.
It does, and I think, sadly, Apollo, I think it always will, for as long as we have a structure that is as it is, where they are individual businesses to all intents and purposes. But Ruth, the notion of funds being available for these things is something you and I mentioned in the last 24 hours, because I'm aware that the surgery I attend, they've had horrendous problems with access with the telephone system. Interestingly, they've just had a change of senior partner, which we only found out about because my wife had to make an appointment, and she was told when she asked to see the doctor we've always seen, he's no longer with us anymore, and she saw a new lady who was absolutely excellent with her, which is good to know. And maybe it's the change of partner that's led to this, but they're introducing a new telephone system. They're drawing, we think, on funds that are available. But you mentioned that to me, Ruth, didn't you, that there are funds available for them to do that?
Yeah, so we have Rose Ewings here from the CCG. So I know that Rose was going to update us on a few things. So I think this might be sort of heading into that area at the moment. So can I just check before we move on to that, though? Is there anything else that anybody wants to ask of any of the reps that have been to any of the meetings, so that we can just make sure that we've finished the item?
Yeah.
Just to say that
thank you for raising that.
I do always raise this point that we're continually receiving, complaints about people not being able to get appointments. 3 different patient participation group representatives have attended this primary care commissioning meeting now and raised that issue. And the CCG has areas of underspending of like £1 million. And even there, a GP said, can't we use some of this money that we're not managing to spend on addressing appointments, and whether that's employing extra staff or something like that. So I think there's just like a lack of vision, really, and I agree that there's nothing being done strategically to take this seriously and address it.
And again, you're right, absolutely. I think some surgeries and practices are taking it very seriously, but not all by any means. And thank you and Apollo for raising that. And that's, as Ruth said, something we can perhaps go into with Rose if she doesn't mind us dropping that bomb on her, as it were. But before we do, as Ruth said, does anybody else want to contribute anything on any external meetings that they've attended or anything they've read in the papers that have been circulated from those that have? Are we all happy to do that? Right, let's welcome then, whether she feels welcome after all that, I don't know. Rose Ewings, as always, from CCG and the ICS, wearing, I don't know which hat you're wearing, probably both of them at the same time.
I'm going to put the ICS hat on while we talk about primary care.
All right. Before we get into ICS and all of that, there, do you want to just relate back to the point that Apollo and have raised, while it's still fresh in our minds, this whole issue of access to GPs, access to facilities, telephone systems, all of that?
Yeah, no, I'm happy to do that. Also, put my CCG hat on. It's probably tin hat at this point, but I think what we are talking about, and I think it's been mentioned before, I'm not sure it's come to the steering group, is the Winter Access Fund, which is funding that NHS has made available at a national level that we have a portion of to support access specifically. And it is a plan across Coventry and Warwickshire, supporting exactly and tackling some of the issues you said. There is funding for telephone, there's funding for communications. One of the things I talked to you about yesterday, Stuart, in terms of what we've got and letting people know about additional roles. There is support for some of the additional roles as well and how we can get those in practice. So there is there is a plan, there is a strategic plan as to how to address this at a Coventry and at a system, Coventry and Warwickshire-wide level. I think what would be useful is there is material I can circulate about it. So rather than, obviously appreciating I've got quite a small slot, rather than trying to go into the depths of it now, where I'm very much cited on the comms piece, and I know what's happening in the wider bit, but I think it'd be really useful if I can get that presentation and that information about what we are spending money that we have got on, without going into sort of underspend and how that it is difficult to use CCG monies for individual GPs. However, the Winter Access Fund is different. It is designed for us to put into GPs to support them. So I think that's probably the first thing, would be to get that round, to understand that it's happening. It was one of the things that I wanted to raise today, that it was meant to be happening at the beginning of the year. However, because of the booster, because of Omicron and everything else, there were a couple of weeks where actually primary care was desperately trying to boost everybody instead of looking at the Winter Access Fund. So we appreciate that has been a pause in that, but it is all systems go. So let me get that detail to you, and then either we can pull together a discussion if people want us to come and talk to a specific group about that access. I absolutely, in the CCG, absolutely appreciates that access to GPs is vital. I think a lot of what we want to try and do with with the Winter Access Fund it is all about improving the access, but it's about talking to people as well. It's about letting people know what is different when we are making successes. There's a lot about some of the new roles that we've got coming in. There's a lot about extended access, which is still running, which might help people access appointments out of hours. So there's quite a bit happening, but I do think sort of first step would be to get you that detail that's broken down in terms of all the various initiatives that are going to happen, and then we can either come back to the next steering group, or if you'd like a discussion in between, then I can facilitate that as well.
That'd be really helpful if you could do that, Rose. Thank you. Circulate that to us. We'll make sure it goes around to everyone. But I think at the same time, Ruth, I don't know whether we can maybe, because Apollo and Ed have quite rightly this morning highlighted that this is an issue that keeps on coming up and doesn't seem to be being resolved entirely satisfactorily. We'll obviously read what Rose sends us with interest, but whether we could pull together some sort of session with the CCG or whoever else may be relevant to this separately for anybody within the steering group who wants to attend can actually contribute and just see if we can find out why it is being a continual thorn in the flesh, as it were.
So
if we can do that, that would be good.
Yeah, no, that sounds perfectly sensible approach. So yeah, so let's see the information. I think the other key thing is for us to understand, hopefully the information will contain this, is what the timelines are, isn't it? So obviously sometimes plans and developments in the NHS take a little while, don't they, to be implemented. So that's something to understand. So we've had a series of meetings which sort of came to an end with the lead in the CCG for GPIT, which were also quite useful. So maybe that's something to think about again, so that there are always pieces of work which are sort of in the pipeline or kind of being developed, aren't there? And so trying to get a handle on some of the things that are going on would be useful.
Yeah.
And members should be aware, and I think we have mentioned it before, just to remind you that we have been involved in a number of meetings about specific practices that were causing some concern and were thrown up to us by members of the public. So it isn't as though we've been sitting back and not doing anything, nor that indeed the CCG has not been doing anything. So I think if we can take it forward in the way we just suggested, that would be really helpful. So Rose, if we can move on then, as time is pressing for all of us, to the latest developments you can tell us about regarding the CCG and the ICS, so you can put both hats on at the same time now.
So I think what I was going to talk specifically about the Winter Access Fund, and if in terms of timeline, if it's any reassurance, this is February, March. It should be the initiative should all have started in terms of funding committed and so on by the end of March, my understanding. So it's not a sort of something we're looking at for next winter. It really is trying to sort of pick up those bits. So I think that's a useful point. Wanted to come back very quickly on a couple of things in terms of previous discussions regarding the urgent treatment centre in Coventry, what was previously the walk-in centre. You may laugh at this, but the change to urgent treatment centre was meant to make things easier in terms of communications at a national level. The idea being that an urgent treatment centre, wherever you go in the country, delivers the same range of services. So that's access to X-ray, access to meds in certain ways. So it was actually about the changing of the name was about a standardisation to make things easier. But I appreciate it. It happened ended up in some places happening during COVID. So communications about why we've changed the name probably haven't landed. And it's one to revisit. I've sent a note already to UH to think that we might want to just sort of mention that to people. I think fundamentally what we said was very accurate is I've done engagement across various services in the city of Coventry, and nobody has any conception that they are different services. And it usually you can be halfway through a conversation before you go, oh, no, you're talking about the walk-in centre, you're talking about the urgent treatment centre, and I was asking about your GP, just because they're on different floors. So I think that there is something to look at on that. So, and also just to pick up a point with a UHCW change running, I think it possibly wasn't clear. They've always run the service, but they have subcontracted it out previously. It is now not subcontracted, it will be run directly by UHCW. So that's the only change. They've always had responsibility for the service, but now they will be doing directly rather than subcontracting it out to who I believe was Virgin Care that were previously delivering service on their behalf. So hopefully that helps clarify that bit. So ICS, my ICS hat's on now. People and communities. So I came to talk to you before Christmas in person, which I miss. So I came to talk to you before Christmas about where we were with people and communities and the developments on that. I'm going to share with Ruth, because I forgot to after our meeting yesterday, I'm going to share around where we've got to. And what we've done is sort of following a conversation, following all of your feedback. I've spoken to Healthwatch Warwickshire as well. Obviously, we haven't done sort of formal engagement on people and communities yet, but I've talked around with our engagement leads, talked to some of our key contacts, and what we've developed based on that is what we think there's really two steps to people and communities. One is absolutely how, when we become an integrated care board, as I talked about last time, how will we support the priorities of the integrated care board of inequalities, of some reducing the elective backward, all of that. How will we support that through engagement and involvement, while also ensuring that we put people at the heart of everything we do, and that's not just a strap line that we say, it's actually a thing that we do. So I think that's one part of the strategy, but also I think the other half of the strategy is that acknowledgement that we're not there yet, that we haven't got the mechanisms in place. We do work in silos. I think Helen mentioned it earlier in the UHCW thing, and that's really, it is how we feel. And I raised this at the previous meeting as well, but we don't join up our insights as well as we could. We don't have those conversations at a Coventry level. We've talked about sort of the burden of involvement falling on people, and we know that now that we're going out, to talk to people, and they're like, well, CWPT came to talk to us last week, and then you're coming to talk to us about the same thing. What are you actually doing about it? And we don't always have a very good answer to that question. So the other half really of the strategy is talking about how are we going to get from the position we are in now, where we do work in silos. There are pockets of brilliant practice. There's some really, really good stuff happening on, but it's how do we bring that to a system? So not so we're all doing things in the same way, because you can't engage in the same way across the system, because there's we have a very, very diverse population that needs to be engaged in absolutely different ways. It's not about saying that one way is wrong, it's about kind of just coalescing and saying these are our aims and principles. So with that in mind, I've drafted, based on our feedback, and they are first draft, what we think our mission is, not as organisations, as partners in the ICS. What is our mission about people and communities? We say, people are at the heart of everything we do. That's in our ICS vision. But actually, how are we going to get that, and what's that in practice? So Ruth's going to share those with you when I send them to her after the meeting. And I really would appreciate feedback. conversation on them if you think it's the right direction that we're moving in. Anything else we need to add? It is quite top level at the moment since it's ICS, and there will be a lot more detail to come as we develop it. But it's really that sort of starting point. We talk about people being at the heart of everything we do, which I think is absolutely right. But I think we never really say why and what the benefits are of that. And I think that's the kind of the shift that I'm trying to make with this. So should I pause there? In terms of very conscious of time as well.
Please,
that's all good, I think. So I think, yes, so we'll send some more information round, and then Stuart and I and other people obviously in lots of conversations in terms of the direction of travel, in terms of engaging with people and communities. And you'll see from our activity report that we've also sort of beginning sort of our own work, which will sort of feed into this. It's not separate. It was sort of take forward the whole kind of agenda, really, in terms of where our what used to be called our good engagement charter fits in going forward as well.
Just one other.
Thank you, Ruth. Anyone else want to contribute at this point before we move on? Do put your hands up if you want to say something. We'll come to you if we can. If you're okay, then do continue then, Rose, if you have more to tell us.
I think it was the only other point, and I think we've touched on this, is the change in the dates for ICS. You're probably aware that the earliest that we will now become an integrated care system through legislation is the 1st of July. That's based on a national change. At the moment, it's been pushed out, but until the bill becomes law, it becomes legislation. Obviously, a lot of this can't happen. The engagement work can still happen, and I think it's really important that that continues regardless. Our timeline has moved slightly, so rather than we were meant to submit our strategy to NHS England in March, that's now not the case. It's now will be May, which is great because it gives us more time to actually talk to people about it. And I think this is a strategy about how we involve in co-design. We have to actually do that through involvement in co-design where possible. So I think that in that regard, from our perspective, people and communities, that is good. But it's just that awareness that at the moment, the date that we're working to is the 1st of July. But it is dependent on legislation, and I'm not quite sure what's happening in the Houses of Parliament at the moment.
Good, thank you. And of course, as we said the other day, and as I think we mentioned earlier this morning, hopefully it proceeds without any further delay, but who knows? I mean, it's an ever moving feast at the moment, isn't it? Getting all these things in the right order. But anyway, thank you, Rose. Anyone else want to comment or question anything that Rose has told us while she's sitting there? Everybody happy?
Stuart,
David,
I've
yes,
got
please.
my hand up, yeah. Rose, Integrated Care Systems, a wonderful title. I'm still not sure how social care fits into this. I know that we've got legislation going through regarding how people are going to be paid for in the future, but surely this sector should be part of the whole process. It shouldn't just be the NHS.
So just to clarify, I mean, you asked that the social care and local authorities are very closely involved in the development of the ICS and will be part of it. And I think that's one of the biggest shifts with the Integrated Care Board, which is the organisation that will hold the statutory funding going forward. We'll have representatives from local authorities on that board as part of the decision-making process. And I think that is a really important change in how we are bringing that along. Is that the right context for your question? Or
Yes, yeah, it is, yeah, because there's been some doubt as to how much talking has been going on with the social care sector. And, you know, if there is this hopefully seamless transfer between particularly secondary care, hospital care, and care homes and domiciliary care as well, then if that's going to work better, it'll work better under an integrated care system, won't it?
That's the plan.
Yeah. Good, thank you. That was all.
David,
I think
is
it's. I
nothing
think
of
it's
an-
just. I just want to say, I think it's really challenging, I guess, for people to get their heads around the new structures at the moment, isn't it? So, I mean, I think it'll come soon in terms of some of these bits are going to start existing in shadow form. So once things kind of get a bit more real, then it kind of and when you've got people coming into the other posts, for example, on the integrated care board, then I think it will start to become easy to kind of explain it. See what I mean in terms of what it's actually going to be, who's there, and then the sort of direction of travel in terms of its purpose and its focus, and then obviously there are other layers that then need to be put in place within the whole system as well. So you know, we're on a timeline. So some bits are currently scheduled to exist from the 1st of July, but not all of the bits. So that's also to be borne in mind. So I think it's fine to be a bit confused at the moment.
Yeah, and I would absolutely agree. And although we have many diagrams and we try very hard to explain it, it is still theoretical. It feels theoretical at the moment, and I think that's particularly when we've called everything IC something. Having an ICB, an ICS, and an ICP is not the most helpful approach, but we are where we are, and I think we're just trying to communicate that at the moment. We are planning, and I do hope as part of people in communities, but just part of that wider transition, to start going out and talking to people a bit more about what it means, but in real life, what it means for people, not just in that sort of theoretical bringing together of boards and this, that, and the other, but actually saying, as a patient who has been waiting for surgery for a year, this is why it will be better if we're an ICS. And I think that's the conversation we haven't had yet. And I think that's the conversation that's really important for us to have, to take it back onto an individual level and say, what does this mean for you? Not what does this mean theoretically? What's my governance structure? But as a person living in Coventry, why is it going to make your life better?
That's excellent, but I go to something called the Adult Social Care Stakeholders Group meeting, where there are always a number of officers from social care in Coventry. And when I brought this up, integrated social care system with them, they're pretty ignorant of it. They don't seem to know very much about it. And again, these are people that presumably are going to be at the forefront of any changes. And we are in February now, and even July is not that far off. So yes, I want Coventry people to know about it, and Warwickshire people for that matter. But these are the people, these are the officers, and they say we haven't heard much about it.
Yes, and I mean, I have one of the things with this AIMS document that recently circulated also has gone, and I have discussed already with our local authority, my local authority counterparts, engagement teams, and so on, that this is the plan and this is what's happening. And I've got a meeting with everybody on Monday actually to take them through the same document. So it is part of it, and that's part of what actually I was explaining earlier, is that what we're doing, what we have to do is, as an ICS, work better together and understand what we're all doing. Before we start talking even about co-production with patients, we need to be co-producing with each other. And I think that's a really important first step of acknowledging it's not where we've been in the past and what it is where we need to get to.
Thanks, Rose.
David, you're quite right to raise the issue, though, that there are people and organisations that do seem to be well behind the curve, if you like, particularly in Coventry, sadly. And conversations Ruth and I have both been party to, and indeed with Rose, where we've said Coventry has generally been behind the curve a little bit, but there are reasons for that. Other areas seem to be ahead of things. That doesn't mean to say they're necessarily doing better. They've just got to a certain point for all sorts of reasons sooner than we have. What I'm also aware of is, as we sit down in meetings with people over this, whereas maybe a couple of months ago they'd have been, as you say, apparently clueless about it, we sit down with them now and, hey, somebody somewhere has actually kicked backsides or pulled the plug or whatever it is they have to do, and suddenly something's there for us to discuss and see what, and things are beginning to move on a bit. At the same time as all of that, when the Secretary of State stands up and says there's going to be a delay, that doesn't exactly incentivize, encourage people, does it, to move forward as quickly as maybe they should. And there are a lot of issues, believe me, caused by that delay. Again, I mentioned Jagtar Singh a little earlier. He and I were discussing this the other day, and one of the critical things that people seem to brush aside, oh, well, we'll sort it, it's a technicality, is actually moving it on 3 months will have an impact on the finances of the whole thing, because you can no longer have a straightforward financial year. It's going to be probably a financial year minus 3 months, or will it be 12 months plus 3, or will the financial year start in the middle of the calendar year and therefore doesn't fit with anybody else's financial year? There's all sorts of things like that, detail, which sound terribly boring and people think they can solve with technicalities, but they're not necessarily readily solvable. And there's a lot of issues under the surface like that do need to be resolved and are being worked on, as you say, David, by those who suddenly realize there's a job to do. But we are where we are, I'm afraid. So anybody else with anything they want to contribute, please? And Rose, thank you again, as ever, for, with all your hats, coming and joining us. Very good to see you. Anybody else want to say anything or comment before we wind it up today? No, everybody done? It's been quite a busy, as I said at the start, it would be a busy agenda, and I'm grateful for everybody for staying with us, particularly those of you who've been watching on YouTube. We will do it all again, believe it or not.
Stuart, yes, I just mention paper 8? It's okay, it's nothing to discuss about, but it is there in the papers pack. So this is where I've put together some hopefully useful information for steering group members about different developments and reports that have come out related to particular service user groups or issues. So you might want to have a read. So not a surprise, NHS dentistry is at the top of that, but there has actually been an injection of money into NHS dentistry by NHS England. So you know that Healthwatch England has been working around influencing around NHS dentistry and the issues that patients and the public are experiencing.
Good, thank you. Yes, paper 8, do study the contents. Thank you very much. As I say, that's it. If you've been watching us on YouTube, thank you. If you've been attending the meeting, thank you, all of you, for being with us, members of the steering group, and we'll do it all again with great success and joy, hopefully face to face on the 5th of April. Until then, thank you very much, and good afternoon. I'll go and get the bins in now.